It is said that we should always start with doubt and end up with certainty. And this holds true with strabismus also, that if you're already sure that you're more likely to make a mistake, so always be slightly cautious and be slightly careful, then only you will reach the right destination. Now, complex strabismus can start at so many places, as you know, along the course of these CNS and the nerves. You can have things like skew deviation, which will be supranuclear. Then you can have CCDDs, which can arise at the level of nuclei and nerves. And you can also have acquired conditions, which can be either nuclear, or they could be fascicular, or they could be in the subarachnoid space, or in the more peripheral course in the orbit. So all these locations, by their anatomical landmarks, one should be able to distinguish where we are dealing. The problem is where. Now, in these cases, we have to be more careful about history examination, because these are situations which are a bit more complicated and misleading. So one needs to know that is it congenital or acquired, because both presentations are going to be different. You also need to look at the family history and systemic history, if somebody is having diabetes or hypertension or any other problem. In children, things like low birth weight, prematurity will be important. And another thing to keep in mind is abnormal head posture, which can be very subtle, and if you are not looking for it, you may miss it. So always look for an AHP. It may give the problem away, like a DRS. You may be able to figure out by an AHP or a 6-nerve palsy. Poor vision, of course, can be because of amblyopia, refractive error, and so many, maybe there are CNS issues. So visual acuity is very important, like in every aspect of ophthalmology. The visual assessment is very important. Then we have to look at the ocular deviation, limitation of ocular motility, and abnormal eye movements like nystagmus or some aberrant innervation, and history of trauma and diplopia is also very important. Diplopia obviously will have to be analyzed in more detail. Now, in examination, we need to have systemic evaluation, visual acuity errors, and amblyopia. AHP, I have said, we need to examine what are the components, and is it just a tilt or a face turn or this thing, chin up or chin down. Then we need to look at, is there a primary deviation and secondary deviation, and which is the fixing eye, because that is important at times, because person may be preferring to fixate with one eye for different reasons. So we need to look at that. Deviation in 9 cardinal gauges and 3-step test, and evaluation of torsion is very important in some of these cases, because this may give away the diagnosis. Then we also need to do tests for muscle function, for restriction or for paresis, or both, because some of these could have an element of restriction as well as paresis. So one needs to see how much is the restriction and how much is the paresis, and what is the consequences on the ocular motility. Now we need to look at diplopia charting, Lees charting, and in relevant cases we need to do ultrasound, orbital ultrasound, and CT scan of the head and orbit, and MRI brain and orbits, and linkage analysis in whatever cases it is relevant. Like if you're suspecting a chromosomal problem, then you have to do linkage analysis is important. So you have to tailor-made accordingly. Now, there could be diagnostic dilemmas in these cases, because there could be a mixed picture, like you may have a DRS with CFM, or those combinations are possible. So it may not be one single diagnosis, it may be a mixed picture. So we need to look in a more broader way and in a more open way. And very important to know what to treat, what not to treat, and when not to treat, because everything which you see you may not always be a must to treat it, because treating it may be more difficult, it may create more problems. So one should always know the indications, contraindications, and how we are going to manage it. Treatment can be surgical, non-surgical, so always don't rush for surgery. If there are only clear-cut indications, then only we need to go for surgery, otherwise it's better to be conservative. Now we have a distinguished faculty. They don't need any introduction. Professor Pradeep Sharma is well known. He is going to speak on third nerve palsy management. Dr. Sumita would be coming. She is in another session. She will be speaking on Duane Syndrome. I'll be talking on CFUM, and Dr. Subhash Dadia will be talking on MED, and Dr. Shreya will be speaking on strabismus due to muscle injuries. So I would like to invite Dr. Pradeep Sharma to give his talk on third nerve palsy management. Dr. Pradeep, please.
Thank you, Professor Pandey. Thank you for including me in this session on dealing with complex strabismus. And I'll be talking on third nerve palsy. Different strokes. So we may have different presentations of third nerve palsy. And as you all know, it is a condition which is otherwise also a complex problem to manage. So what are the kinds of challenges that third nerve can throw? So I have no financial disclosures on any of the things that we'll be talking about. As we all know, third nerve palsy is something which will present to us in the form of patient having a ptosis, having an exodeviation because of the medial rectus underaction, elevation limitation, as well as depression limitation in abduction. And in addition, if we look, there will also be an involvement of the pupil. Mostly there will be anisocoria or mydriasis, but sometimes there may be pupil sparing third nerve palsies. And in congenital conditions, you may sometimes have an autonomic pupil. So what are the important considerations? As we said, third nerve supplies all the extraocular muscles except lateral rectus and superior oblique. So it is having a major role to play in the ocular motility. It also supplies LPS in addition, the levator palpebrae. It also supplies the internal muscles of sphincter and the ciliary muscles. So the involvement of accommodation and the pupillary reactions should never be missed when we are examining a third nerve. Then again, there can be a presentation differentiation in the basis of whether the third nerve nucleus is involved, or it's a fascicular involvement, or is it a problem in the orbit when the third nerve has superior and inferior division, and the involvement can differ because of that. And then, as we said, some of them may be having an ischemic mononeuropathies, which are sparing the pupils in 70% cases. It many a times may be partial or may have recovered partially when it presents to you. So you have to keep that in mind. And then in addition, there can be aberrant regenerations. It is like a situation in like many nerves are passing in a bundle, and after being a cut and then regeneration happens, there can be a very simple possibility of a miswiring or having different connections. So this is what happens in aberrant regenerations. But mind you, aberrant regenerations are also indicating that it is a trauma or some injury which is going to disturb the passage of fibers. Ischemic mononeuropathies are usually not going to have an aberrant regeneration. And then there may be associated neurological deficits which we have to take care of. Now here is an example of a ischemic right third nerve palsy. And if you see this individual who is 70 years old, he is having limitation of adduction, elevation and depression, and the eye is exotropic. He also has a ptosis of the right eye, and if you look carefully, there is no change in the pupillary size. So there is pupil is sparing in this case. So this immediately should raise our suspicion that is some ischemic problem, and we should then be looking forward to this. But mind you, 70% of ischemic mononeuropathies are pupil sparing. 30% can have involvement of pupil. So it doesn't work the other way. So if you have a pupil sparing, you have to keep in mind. And secondly, if there is a partial third nerve palsy, there may be a pupil sparing even if it is not ischemic. Because in that partial, it by itself means that it may have not involved the pupillary fibers. How do we manage these cases? So one is complete ocular motor diagnosis should be made. We should investigate for the cause. So whenever a paralytic strabismus comes to us, apart from examining the ocular motility, we should always look into the fundus to see any papilledema and also the fields, which will give us an indication of associated neurological problems. Then we have to investigate for the causes, which may be vascular ischemic. So hypertension, diabetes, coronary artery disease, or CVA should be ruled out. So have a profile of this in a patient who is having, as shown here. In a study done by us in AIIMS RP Center, we had seen that 60 cases of ischemic mononeuropathies. Out of those, 25 had diabetes mellitus, 15 had hypertension, hypercholesterolemia may be there in 8, and lipid profile disturbance was there in 20 cases. We need to investigate these cases. And in addition, we should also do neurological evaluation whenever there is a pupillary involvement, all cases. If the pupil is spared, you should follow these cases and in 5 days time call them back. If the pupil gets involved in 5 days, they may have to be investigated for imaging. So keep that in mind. Once we have established that there's nothing else to be done neurologically or they are non-ischemic, then we have to see how do we manage. And regular follow-up is done 6 weekly. And then we see after 6 months or 9 months, if there is no natural recovery, then we may require to do surgical management. For ptosis, many a times, clutch glasses can be given to the patient if there is a severe ptosis. But otherwise, you may do a sling surgery to lift the lid. But mind you, there will be a risk of, because of poor bells and exposure keratopathy. So that should be kept in mind. In surgery, we are going to determine the fixating eye, which is going to determine the target deviation. We'll have some cases that we have dealt with. Now this is case 1 in which there is a right eye third nerve palsy. The eye is moving up to the midline, just barely so. So we may get away by doing an R&R, or nowadays we may say recession and plication surgery. And this is what was done in this individual who himself happens to be a doctor. So we did a post-op after the LR recession of 24 millimeters, a supramaximal recession of lateral rectus, and a medial rectus plication of 8 mm. And the advantage of doing plication in paralytic squint is this, that if we are not sacrificing the anti-segment supply. So we can always do vertical rectus if they are recovering and if we want to improve the adductions. This case 2 shows you that when the eye doesn't cross the midline, what can we do? And LR was not tight. So in such a case, we may do a LR split transposition to medial rectus. So it's a nasal transposition of split lateral rectus. This has yielded very good results, and this can be done in such cases to improve the exotropia situation and improve adduction to some extent. Some cases may also have significant vertical deviation, and these cases what we may do is horizontal deviation correction by the split lateral rectus to MR, like in this case. And in addition, the vertical deviation is taken care of by doing the vertical muscle surgery in the other eye, the contralateral eye. So here 2 muscles we have taken care of in the involved eye, then the verticals we can handle in the other eye to balance the vertical tropia. Like in this case, and after doing the superior rectus recession in the other eye, the left eye, you can see that the improvement of ptosis also is there. The pseudoptosis component has got corrected. Now, this case 4 shows that if there is a tight lateral rectus, what do we do? If there is a very tight lateral rectus, you cannot do a lateral rectus nasal transposition. And in such a situation, either a supramaximal recession or a periosteal anchoring of the lateral rectus is done. So in this case, periosteal anchoring of lateral rectus was done. And to improve the adduction, we have also done a medial rectus plication or resection. In this case, resection was done. When there are very tight lateral rectus of exodeviation up to 90 prisms, in such situations, a medial periosteal anchoring of the globe can be done to salvage the eye in the midline. And this is what is another procedure which is possible to handle such large deviations. And you can approach the muscles in this case through the precaruncular approach. Aberrant regenerations, as I said, we may have to tackle. And these are special situations. And what we need to do is look for what is the aberrant regeneration. In situations when the lid gets corrected or lifted up because of the abduction effort, we can do a contralateral LR-MR surgery. And as you see here, the left eye was involved, the right eye lateral rectus recession and MR resection has been done, and this has lifted the ptosis because of the aberrant innervation being used. This is another case in which you can see the left eye in which there is a ptosis and the right eye surgery has been done, and you can see the improvement in the ptosis along with the deviations being corrected. The case 7 shows you the acquired partial third nerve palsy. That means there is only the inferior division which is involved in this case, and such a situation, see, you can see the superior rectus is free and the lateral rectus is also not involved because it's a third nerve. So you do an FDT to see whether the LR and SR are not very tight. And in this case, I chose to do a modified inverse NAP procedure. And here what we are doing is NAP procedure for depression. That's why it's inverse NAPs, and it's modified by the virtue that we have taken the medial rectus, resected 6 millimeters and reinserted at IR, and the lateral rectus has not been recessed, just inserted at the right inferior rectus side. And as you can see, the post-op results has given considerable improvement in depression in abduction, as well as the exotropia has also got corrected. Another case in which we have a residual third nerve palsy with marked lateral incompetence. Now this was a residual third nerve palsy in which surgery has been done earlier previously. A lateral rectus recession of 12 millimeters was done with the medial rectus plication 6 mm. So what we have done in this is that we wanted to set it right in the incompetence, and I chose to do a Scott procedure on the left lateral rectus, and here resection of 6 mm and the recession on the same muscle. Mind you, it is the resection and recession on the same muscle that is known as the Scott procedure, and this improves the abduction incompetence much effectively. The last case which I would like to show is a Rere surgery. So this individual had been operated elsewhere twice, and he was still unhappy because of the large exotropia. So what I did was explore the lateral rectus and then recessed it 25 millimeters. That is 7 millimeters hang back, 18 millimeters on the sclera, and inferior rectus belly transfer to medial rectus, which again does not compromise the blood circulation. And you can see that the eyes have been straightened and there is an improvement in adduction. So important points to remember are deviation in primary position and other gazes should be noted. Fixing eye to determine the target deviation. Look for incompetence. Realistic goals should be set. We should counsel the patient because all the gazes cannot be improved in most of the individuals. Individualize the treatment. FDT for lateral rectus should be done, and if it is very tight, supramaximal recessions or even periosteal fixations may be done. If it is not very tight, then split LR to MR can be done. An option for the contralateral muscle surgery should also be kept in mind if there is an aberrant regeneration. So we have to be a squintellectual, and we can have very good results if treated properly. Thank you all for a patient listening.
Thank you, Dr. Pradeep, for very informative talk. Only thing I wanted to ask you one thing. Well, you're doing periosteal fixation in some of these cases, and you cannot transpose vertical recti because they may have no force. So the abduction is going to be quite limited. There will hardly be any abduction, and that will create problems when the person looks in that gaze, particularly. Okay. So I think third nerve palsies are a very complicated situation because 4 muscles are involved. So one has to make a compromise and see how best to put the situation across.
Correct. So I think we need to counsel the patient. Most of the time we are interested, first is to improve the primary position. Second is to improve the primary and down. These are the two important gazes for us so that binocularity can be achieved. The rest the patient can have a head turn and manage. So the lateral deviations are going to be affected whenever we are doing a procedure like periosteal fixation, lateral rectus periosteal fixation, or a medial anchoring of the globe. Both ways there will be a lateral abduction. Even in the lateral rectus transposed to the medial side, we are again taking away the lateral rectus force altogether. So we do have, but they are still very happy patients because the primary position is something which they, and many a times they can learn to move their head, and most people cannot know that they have any problem.
That is true. It's a very difficult situation. So I think whatever they gain, they are quite happy.
So that's why counseling is important. You need to pre-counsel these patients, what is expected from you and what can be done.
Yeah. So and one thing more, I think about torsion we should keep in mind because the fourth nerve is the only one left at times. So if there could be some little, if there is torsion, that also needs to be
if the torsion is there, then you should touch the superior oblique. You may have noted that I have stopped doing superior oblique transposition for third nerve palsies. I think 15-20 years back, following Dr. Prem Prakash's time, there was, in those days, the procedure described was superior oblique transposition. Superior oblique was used to adduct the force. But in such a situation, you will see that there will be severe compromising movements because the superior oblique is supposed to be lifting the eye in looking down. So it will give you weird movements at times. So that's why we have stopped doing the lateral, the superior oblique transposition, the Peters modification, or the original.
That was, I think, initially described by Scott, I think.
Scott and Peters modification by cutting the superior oblique 20 millimeters and then removing from trochlea and then doing it.
And it went out of vogue slowly now.
So I think we have stopped doing that.
So third nerves are a very complicated situation, and I think need someone like Professor Pradeep Sharma to handle them. All of us have done, but results can never be always 100%. So patient has to be counseled and told that he should not expect everything to be perfect for him like the other eye. And
Thank you, Dr. Pandey.
Thank you so much, Dr. Pradeep. Dr. Sumita is not here as yet, so I think I move on to my talk, and then Dr. Subhash can give his talk. ये मेरा टॉक लगा दो वापस. Now I'll be talking about CFUM. This is another very complicated presentation, rare presentation, but once it is there, it is quite difficult to diagnose and difficult to manage because we don't see so many cases. And for beginner, people who don't have very long experience, they might be quite puzzled by the presentation. Now, CFUM is a misnomer, as we all know. It's primarily a neuropathy and not a myopathy. The problem is with the nerve that they have not developed and gone on to the target organ, that is the extraocular muscle. So there is, it's a neurologic problem, not a myopathy. Neuropathy affecting all or part of the cranial nerve 3, nucleus, nerve and its innervated muscles, and or trochlear nerve and its innervated muscles. Fibrosis is variable and secondary event, it is not the primary event. So it may be a lot of difference from one patient to the other. So that will change the picture, clinical picture in different ways in everyone. And it's a rare presentation, 1 in 1.23 lakhs, 1.13 lakhs or so. So it's a very rare presentation, so you don't see many patients. Now, as we said, these are CCDDs. There is aberrant signaling of the extraocular muscles by neurons in the CNS. There are basically two mechanisms. One is the correct axonal targeting of the extraocular muscle, that is by KIF21A. This is kinesin, which transports cargo where the nerves are developing. So if there is a problem, this is not going to happen and the innervation is not going to be through. The other is motor neuron development, which are things like PHOX2A, which is TUB3 and TUB2B. So these are basically, they affect the CNS development. So there is a more generalized and more systemic problem. When you have problem with the TUB3 and TUB2B particularly, lot of aberrant innervation can be seen in these cases. We will be coming to that. Now tubulins these are proteins which are very important for neurogenesis, for neural migration, neural differentiation, and crucial for CNS development. These are basically microtubules which have these tubular proteins, and these microtubules are composed of the tubulin proteins. And TUB3, TUB2B fall in this beta tubulin category, and these, as I said, these are very important. If there is a problem with these, then the CNS development is going to be affected. So a lot of problems will arise in the CNS, systemic, and at the level of extraocular muscles. Now, as I said, in these CFUMs which are involving TUB3 and TUB2B, you will have malformations of the cortical development, dysgenesis of the corpus callosum, absence of several peduncles, microcephaly, microgyria, polymicrogyria, vocal cord paralysis, and intellectual disability. So a lot of things can happen. We have to look at the systemic issues also in these cases. There could be systemic associations like facial paralysis, cognitive behavior, Kalman syndrome, sensory motor axonal polyneuropathy, bilateral inguinal hernias, and crypto-occultism. So we need to examine these patients systemically also. A lot of findings could be there along with. And you can have ocular associations like high refractive errors, astigmatism, amblyopia, optic nerve hypoplasia, typical colobomas, synesthetic divergence, convergence, and Marcus-Gunn phenomena. This is also likely to be seen with TUB3 and TUB2 variants more often. It can be seen with KIF21A also, but more commonly seen with TUB3 and TUB2 variants. There could also be hypoplasia of the sixth nerve in these cases. Now, there are at least 8 genotypes in CFUMs. With KIF21A, we have CFUM1A and CFUM3B. With PHOX2A, we have CFUM2. TUB3 has CFUM1B and CFUM3A. TUB2B has CFUM3A, CFUM3 with polymicrogyria, which is a CNS abnormality. And Tuchel syndrome, we don't know the responsible gene as yet. Most are autosomal dominant with 100% penetrance and expressivity. And autosomal recessive are CFUM2 and Tuchel syndrome. So these two conditions are recessive. You can also have sporadic involvement, which arise from de novo mutation, but they are rare. I'll be showing 1 or 2 cases. Now, phenotypes have great variability in their presentation. They are often high refractive errors and high astigmatism. So always remember that you could be dealing with a lot of astigmatism, which could be causing a lot of amblyopia, and that needs to be tackled. Restriction of upgaze is sine qua non. All of them, most of them will have some limitation. Even if the eye is in the primary position, there will be difficulty in elevating the eye in upgaze. That is because of the IR fibrosis, which is very fundamental problem here. Usually they have a chin up position and ptosis. Ptosis is there in a good number of cases, but some cases may not have ptosis also. That's possible, they don't have ptosis. There could be an exotropia, isotropia, variable limitation of horizontal gaze. Now, more often you find an exodeviation in these cases, but you can also have an ESO in some cases, and limitation could vary from one shift to others. The 2 children, both affected, may have different horizontal gaze, but vertical movements are going to be affected similarly. So horizontal gaze is very variable. They may have a horizontal deviation, or they may not have a horizontal. Some may have even no deviation in horizontal gaze, but as it goes up, there is a lot of problem. There is poor or absent binocularity in these cases. Now this is showing one family. You can see 3 generations. They are all 2 daughters, the mother and the grandfather. They have very mirror image presentation that shows how penetrant and how expressivity is 100% autosomal dominant presentation, and all look alike. Now, when you look at the motility, you find there are some differences, of course. Like this girl, you can see she is able to move her eyes. There is a limitation of vertical gaze, but horizontally she can move both eyes, but there is in the left eye is moving less as compared to the, it looks like a left gaze palsy in this situation. Eyes are not moving left ways, and right side they are moving. So this is one presentation with an exodeviation, and you can see a lot of high astigmatism here of about minus 4.5. This is showing extorsion in this patient, maybe it's arising because of tight inferior rectus muscles. And this is showing the other girl. Again, you see high astigmatism about -7. And here again you have an exo, but the left eye is not moving so well, and right eye is moving all right. So the limitation of movement in the left eye as compared horizontal movement I am talking. Vertically, of course, there is a limitation, and these can go into an ESO position in upgaze, what we call as A pattern. So that is also quite characteristic of these patients, that they will have an A pattern, but that is again seen more with TUB 3 and TUB 2 variants and less with KIF21A. This one had intorsion, maybe the superior oblique was also involved in this case. This is the mother, almost frozen eyes, and she has had cataract in both the eyes operated. At the time of first surgery, nobody realized that this is a CFUM. It was done in Guru Nanak Eye Center only, and diagnosis was missed. This is showing another family. You can see the mother and 2 children. This is a typical head posture in the boy, elder boy, you can see, chin up position. And father is not affected, and both children and mother are affected. Here, child has no horizontal deviation in this one. It has only vertical problem. There is no horizontal deviation here. This is showing a sporadic case. Again, he had a cataract trauma in left eye, and it's a sensory deviation here, large ESO. This is showing CFMT. You can see that there is, globes are almost fixed to the lateral canthi, and there is very little movement. It's very autosomal recessive and mostly described in Saudi Arabia in consanguineous families. This is something like CFM3. You can see unilateral ptosis. There is typical coloboma, and there is in the other eye there is an ophthalmos with cystic eyeball. There is cryptorchidism and renal agenesis. So this patient had a lot of systemic associations. Of course, we could not do genetic analysis, but the features are very suggestive of unilateral CFM, which had systemic involvement. Some of these MEDs are also with IR fibrosis. They are also like CFM3 with TUB 3 variants. Some cases which have IR fibrosis, they could be CFM3, and there have been some reports that this MED is a unilateral CFM. This may be associated with MGP, facial palsy, and cortical malformations. These associations have been shown. There could be hypoplastic oculomotor nerve in these cases, and variable fibrosis of the IR. And association with TUB 3 pathogenic variants has been shown in some reports. So when we are looking at MED, we should also think of unilateral CFM, which could be there in these cases which are having tight IR. Now, workup would include relevant history, family history, systemic history, the CNS involvement, as we said, that particularly with type 3 and type 2 variants. Facial palsy could be there, cognitive, behavioral impairment, syndromic involvement, and joint contractures. All this systemically needs to be looked into. Visual acuity, amblyopia, we have to see refractive errors because they have high astigmatism. So we need to look at that, and abnormal head posture, which is quite often very classical. Ptosis, LPS function, Bell's phenomena, and corneal exposure are important to keep in mind because they have poor Bell's because it's very tight IR, so they don't even blink that often, and they are prone for corneal exposure. Then, of course, we have to evaluate the strabismus and the ocular motility, and misinnervation, which could be MGP and synergistic divergence. And we have already said that there could be this Marcus-Gunn phenomena. All this can be there in these cases. Now, MRI brain and orbits has to be done if you are going to operate particularly, or if you are suspecting CNS involvement, then MRI brain and orbits has to be done to document CNS involvement or CN 3, 4, or 6 involvement. And you could also have abnormalities of extraocular muscles insertions and thickness. You need to have photographic documentation because whatever you do, you want to see how useful it has been. Then you have to do FDT and fourth generation test, and genetic analysis has to be done in these cases, which is not easily available with us. Now, differential diagnosis will basically mean CPEO, which needs to be distinguished. There could be bilateral congenital third nerve palsy, which is very rare, and you don't see many cases. There could be congenital Brown's, which is bilateral, you may see. Mobius, at times may create issues. And congenital MAD, which is a unilateral CFM, as I said, it could be mixed up. Now, CPO could be either Kearns-Sayre syndrome or Pearson or Mendelian PEO. So all these are variants which can present in different ways, and they may run into each other. So Pearson has other findings also, systemic findings like anemia and diabetes, but it may also present with ophthalmoplegia. Now, as I said, we can have overlapping presentations with CFM, like you may have a Duane's, you have synergistic divergence, Marcus-Gunn phenomena, infantile deviations, Mobius, Kalman syndrome, and hereditary congenital facial paralysis or Newman syndrome. Now, treatment is non-surgical treatment would mean correction of refractive errors with glasses or contact lenses. This is very important because if you don't correct, they will go for amblyopia. So, young children need to be treated for astigmatism. Glasses have to be prescribed. Amblyopia has to be treated, and ocular surface lubricants have to be given to these children because they are prone for dry eyes. Now, surgical treatment, you should be clear about the indications, as I said, otherwise you may end up in worse situation. So, to improve AHP, to align the eyes in primary position, to improve motility, to improve ambulation and gross motor development, and not all need to be put under the knife. So, all don't have to be treated. You have to be clear about what you want to treat, otherwise it may not produce good results. Now, the surgical approach is that you may have abnormal extraocular muscle insertions. So, MRI has to be done before you are operating these cases. You should know some idea about where EUMs are inserted. IR weakenings are maybe enhanced by SO weakening also if there is a need. Denervation causing ET in upgaze may mask and XT that may surface after IR resections. Resections and plications can rarely be done if you do large resections, and some resections can also be done in some cases. And in residual situations, you can also inject botulinum toxin. Ptosis may need to be under-corrected, as Dr. Pradeep was saying in third nerve palsy also, because they are more prone for exposure. The challenges are surgery is difficult due to extreme fibrosity of the extraocular muscles, abnormal insertions. Resections need to be much larger than conventional. There are orbital bands and septi could be there. There is poor Bell's. So, ptosis surgery may lead to exposure, so we need to under-correct. Results are modest, multiple procedures may be required. So, one has to be told beforehand the patient that you may need more than one surgery. To conclude, it's rare presentation, prone for misdiagnosis, congenital restrictive ophthalmoplegia with vertical gaze, could be unilateral, bilateral, with or without ptosis, modest surgical outcomes. Think of COM, CCDD in your practice if you are having a difficult presentation which doesn't fit into anything very typical. Just an invitation, we are having our midterm conference at Nagpur on 19th of this month. So I request all of you to come and attend Nagpur event, midterm conference. Thank you. If there are no questions, then I request Dr. Subhash to present his talk on MED.
And thank you, Dr. Pandey sir, for including me in this IC. I will be speaking on monocular elevation deficiency diagnosis and management. Basically, it is defined as inability to elevate paretic eye from any position of gaze provided ductions are normal in all other positions of gaze. It may be due to paresis of superior rectus and inferior oblique with ptosis, or it may be a long-standing superior rectus palsy. Initially, the term was double elevator palsy, which was coined by Dunlop. It may be congenital or acquired. It may be paretic or restrictive. It may be supranuclear. Now, the term which is more commonly used is MED. It is more accurate term because paralysis of both muscles independently and supranuclear lesions can lead to impaired unilateral upgaze palsy. So now, most oftenly, the MED is used in place of TEP. Causes could be congenital, which could be supranuclear defects, SR paresis, inferior rectus restriction, neonatal hypoxia, in acquired CVS disease, midbrain tumors like pineocytoma, acoustic neuroma, and metastatic tumors, sarcoidosis, and cysticercosis are other causes of acquired MED. It has been classified into type 1, 2, and 3. In type 1, the prominent feature is restriction of the inferior rectus. In type 2, weakness of the elevator weakness is the prominent feature, and in type 3, it is combined type. So clinically, there is limitation of elevation above midline, both in abduction and adduction, and it is very important to differentiate it from Brown syndrome. Then there could be hypertropia of involved eye, and there is presence of ptosis and pseudotosis. Usually there is chin elevation. Usually it is unilateral. Marcus gun jaw winging phenomena is seen in approximately 25% of the patients. This is clinical photograph of one of the patient with the MED. So for diagnosis, it is very important to ask history of onset, and if sequence of events is not clear, then presence of amblyopia suggests congenital etiology. You must look for previous photographs. In acquired cases, there will be history of neurological symptoms. You must ask about past medical histories and general systemic symptoms. In type 1 MED, positive FDT will be there, normal FGT, normal skates, and deeper lower lid folds. In type 2 MED, their FDT will be negative, reduced saccadic velocity will be there, reduced force generation, Bell's is intact, and absent skates above midline suggest supranuclear lesions. In acquired MED, there is acquired diplopia in upgaze along with presence of neurological symptoms. Usually ptosis is not a prominent feature in acquired MED. It may be associated with pupillary anomalies and convergence weakness. Bell's phenomena is usually present, and patient assume a chin-up head position. This is a case of 20-year-old female with post-traumatic MED. FDT was suggestive of tight IR. This is another case of 30-year-old with right acquired MED. His case of sarcoidosis with high age level and high lymphadenopathy in HRCT chest. Another patient, 20 year-old female resident of Delhi presented with chief complaint of diplopia since 1 month. And on imaging, it was found to be case of cysticercosis with cystic lesion in the inferior rectus muscle. This is MRI. And after medically managing the patient with oral albendazole and steroids, patient was orthophoric and elevation limitation also got resolved. So basically, how to differentiate congenital and acquired MEDs. Congenital MED is usually in children. Acquired MED is usually in adults. Age of onset is at birth in congenital MED. However, in acquired, it can start at any age depending upon the cause, but more often in older patients with diabetes, hypertension, atherosclerosis, or serious disorders. In congenital MED, strabismus and ptosis are the prominent feature. However, in acquired MED, acute onset diplopia is a primary feature and ptosis is not a prominent feature. Systemic status, there is no relevant systemic disease. However, in acquired MED, cardiovascular neurological diseases may be present. In congenital MED, amblyopia and suppression are common. However, in acquired MED, diplopia is more common. Various differential diagnoses for congenital MED could be Brown syndrome, vertical Duane's, congenital fibrosis of inferior rectus, congenital absence of superior and inferior oblique, absence insertion of inferior and superior rectus, and superior divisional third nerve palsy. Differential diagnosis for acquired MED are thyroid orbitopathy, myasthenia gravis, orbital floor fracture, third nerve palsy, orbital cellulitis, orbital inflammatory diseases, cerebral tumors. This was one of the patient with ocular myasthenia gravis, which presented like MED and was referred to neurology department for management. Then what are the indications for surgery? In MED, significant abnormal head posture in primary position, significant vertical deviation in primary position, contracted binocular fields, and diplopia in primary gaze. They are the indications for surgery in cases of MED. And in most of the patients, we have to observe the patient because the patient can manage orthophoria with limited head changes. Treatment for MED is surgical and only surgical. So what are the goals for surgery? We want to achieve cosmetically acceptable deviation in primary position. We want to increase the field of binocular single vision, and it is very important to tell the patient that surgery will not cure it. And more than one surgery is required in this sort of patients, and usually these patients, they present to the ophthalmologist with complaint of ptosis, and they want ptosis surgery first, so they have to be considered that strabismus surgery will be done first, and after that ptosis surgery will be done. So counseling is very important in this sort of patients. So what are the various surgical procedures? Optical treatment for MED remains controversial, and treatment should be according to type of MED. And in type 1, which is usually in approximately 75% of the patients, recession of the involved inferior rectus is the procedure of choice. In type 2 MED, NEPS procedure is a well established and commonly practiced procedure. However, NEPS procedure has its own drawbacks because patient loses some ability to abduct and adduct, and effectivity decreases if deviation is more than 25 prism diopters. These are the steps of NEPS procedure. So basically this NEPS procedure was described here. There is vertical transposition of horizontal muscles to the SR insertion. Then this NEPS has been modified in cases where there is associated horizontal deviation with elevator weakness. So in this case, there is transposition of superior half of equally divided up to 15 mm medial and lateral recti for vertical deviation, and inferior half after suitable recession and resection is used for horizontal deviation. This was published in Journal of Ophthalmic Surgery and Lasers. Isotropia and vertical muscle recessions have been found to be effective modality in congenital MAD in one of the Chinese study. Then Sneer M et al. Recommends NEPS procedure with posterior fixation sutures, and MAD with modified NEPS is done for double elevator palsy with the horizontal deviations. These are the preoperative photograph of one of the patients, postoperative photograph. This is pre-op photograph of another patient. This is post-operative photograph. This is pre-operative photograph of another patient. This is post-operative photograph. Pre-op photograph of another patient. So this patient is case of congenital MAD, and this is the post-operative photograph initially after doing the squint surgery and finally after doing the ptosis surgery. So when to intervene for ptosis? So minimum of 6 month waiting is required after squint surgery because magnitude for vertical correction increases with time following NEPS procedure. Thank you.
Thank you, Dr. Subhash, for a very informative talk. I think only thing is if you are doing IR recessions and if you are doing more than 6, then you need to have little medial transposition because it may produce an A pattern because it's also an adductor. So if these are very tight and there's a lot of hypodeviation, hypotropia, if you're doing more than 6.
Sir, usually I limit my recession to inferior rectus to 5.5. I am not going for more than 6.
But some are really tight, and I think you do need once in a while need to do more. But in general, if you're recessing IRs, you should be careful about that.
Yes.
And some cases you can also do IR recession and SR resection where the deviation is not too much. And of course, it's
some
not.
studies have been there in the literature, and one of the studies have been done from our center also. One of the thesis was done in which this inferior rectus recession and superior rectus resection has been used, and they have been found to be useful.
Especially if it is not a large deviation.
Yes.
Because NIPS has its own issues. Dr. Pradeep, would you like to say something?
Yes, I think these are the options. And in addition, even the contralateral elevation, elevator muscles can be tackled in situations when we have already had a deviation which is not correctable by the same muscles being surgery. So the other eye, we have used the total anterior positioning on the IO, the inferior oblique, which is an anti-elevator. So you can have the anti-elevator effect on the contralateral eye to correct the problem of the MED and balance the two eyes. And both the eyes can be then having balance.
Yeah, especially if there is a ptosis in this eye, if you recess the contralateral SR, that works quite well because that by in the contralateral.
In the contralateral eye, along with an IO tap.
Yes.
IO total anterior positioning.
Yeah.
That may also balance the thing. So what you said is right, that first is FDT, IR recession is the first choice if FDT is tight.
Yeah.
If FDT is not tight, then you can do a NAPS or a NAPS with posterior fixation sutures. And the third option is then to do the contralateral elevator muscles.
Yeah, if there is pseudotosis, that part will be corrected, and if there is residual ptosis, that can always be corrected later. So I think that sums up the management for the MED. Now we move on to the next talk by Dr. Shreya. She has very extensive experience in oculoplasty and strabismus, and she's working in a very distinguished institution at Dahod. She'll be talking about traumatic injuries to the extraocular muscles.
Should I do from here?
Please.
This is not the first slide.
ये तो सुभाष का है. डॉक्टर श्रेया का चेंज कर दो.
वो लास्ट में है, ग्रीड करोगे तो दिखेगा. नो अभी था उसमें. Thank you, Professor Dr. Pandey sir, for allowing me to speak in your IC. I'm grateful to speak in front of my senior surgeons, Dr. Pradeep Sharma sir and Dr. Subhash Dedia sir. So it's little hesitation also to speak in front of our seniors. मैं कर लूँ? How it goes down? Directly from here? Okay, so waist down. Okay. So thank you so much. I'll be speaking on managing strabismus post-orbital trauma or any kind of injury. Out of our 12,687 trauma patients, we could nearly see that 14.6% were orbital and adnexal injuries. That has been published. Nearly 10% of the facial fractures are isolated orbital wall fractures, the majority of these being orbital floor. So these all are published data. If we talk about traumatic strabismus, it can be supraocular structures, oculomotor nuclei involvement, extraocular muscles, or combination. So we'll directly talk about what happens to extraocular muscles. So if we'll see, here is the direct effect. Direct effect can be direct damage to the ocular muscle. Second can be pressure effect, that can be just because of cellulitis or orbital edema. Third can be neurological. There can be indirect effect from head injury, concussion, concussion, and there can be a late presentation with local effect. Local can be a deprivational or mechanical because of corneal scar or amblyopia. Distant can be again keratoco-cavernous fistula or head injury. So majority of the next talk I'll directly talk on trauma to the muscle. Later on, if we time permits, then we can talk other. So what can happen to muscle when there is an injury? Muscle, number one, muscle can be contused. Number two, it can be partially lacerated. Number three, it can be completely lacerated. Number four, it can be snapped or pulled into two. Number five, there can be complete total disinsertion of muscle. Number six can be lost muscle. Number seven can be incarceration or entrapment of muscle in any of the orbital floor fractures. Again, when we are talking about incarceration or entrapment, there can be a because of floor fracture. There again are two types of floor fractures, pure or impure. And when there is a floor fracture, for adult and for children, both are different. So this is type 1 floor fracture in adult when there is a elevation deficit. When there is a depression deficit, it is called type 2 antral fracture. When there is both, it can be called type 3 antral fracture. So incarceration happen in children when they present with simple orthotropia in primary position, but when you tell patient to look up, you can, and with the history of trauma, you come to know that there is a floor fracture. So early and immediate repair is must when there is a white eye blowout fracture in children. Number 8 can happen to muscle is flap tear. And number 9 can be slip in his muscle. So this 9 thing can happen with muscle when there is trauma. We can diagnose any of this with proper history taking and gross examination, whatever we see for any kind of the surgeries, including best corrected visual acuity, hypema, facial asymmetry, diplopia charting, hair screen charting, field of vision, intraocular pressure measurement, inophthalmos, exophthalmos measurement, pupil and visual field. Associated with it, we may need to do ultrasonography, CT scan, MRI, dynamic MRI, or sometime electromyogram. So dynamic MRI is the good choice to find out what is the cause. CT changes is always different in adult and children because in children there is the bone is elastic, so there will be a trapdoor fracture. But in adult there will be a teardrop sign because the defect is large and the content can slide into the maxillary sinus. This is MRI of contused muscle. So we have many diagnoses available on radiological investigation, but the most of the diagnoses we can do are on clinical diagnosis, that is through ocular motility, force duction test and force generation test. We all know how to test ocular motility, cover test and everything. Force duction test is the best choice. We can see that which muscle and where it is involved, where it is stuck. force generation test in some time can be done in children with Q-tip, or we can do force generation test in our outdoor patient department also. So you pull the muscle and allow the patient to see on opposite direction, and when there is force generation test, you know which muscle is working, traumatic or. So we have developed our own diagnosis algorithm for this kind of injuries. So whenever there is a blowout fracture with big defect, motility may not show the much motility disturbance, but it may show enophthalmos, where FDT can be negative, FGT can be positive. When there is blowout fracture with small defect with incarceration, it may show restriction in both the fields, but more in the opposite field of the action of the muscle. Both can be positive. Trapdoor fracture may show marked motility, but associated with bradycardia, vomiting, or any kind of oculocardiac reflex, where FDT will be strongly positive. Flap tear of muscle usually produce limitation of the movement in field of action. FDT may be negative, FGT can be positive. Snapped muscle pulled into two definitely will show limited field of action, but full movement in opposite direction. Contusion of muscle just marked depression of the movement just because of pain and edema, nothing else. Partial laceration may show limitation action in field of action. FDT can be negative, FGT positive. Complete laceration again may show limited field of action with good movements in opposite direction. FDT can be negative. Complete disinsertion, definitely FDT will be negative and FGT will be strong positive, will show movements in opposite direction and no movement in the field of action. Combination can happen with any. How to manage this? These are certain red flag signs which needs to be addressed within 24 hours when there is oculocardiac reflex, retrobulbar hemorrhage, open globe injury, CSF leak, or muscle strangulation. But sometimes we may manage non-surgically. Till that time, we may prescribe prism occlusion, or and treatment for abnormal head posture. When there is contusion, so we'll go one by one. When there is a contusion, simple observation, anti-inflammatory, we will resolve the complete restoration of muscle. May have to give steroid antibiotic and no nose blowing. Brown syndrome, when there is a partial laceration of muscle, usually it is seen very well. You can find out the other cut end and you can suture. That gives good result. Sometimes they give weak movements later on, so we may have to assist it with R&R procedures. When there is complete laceration, it is very, very, very difficult to find out. But if patient reports to you immediately, then try to hold the intermuscular septum and chase the muscle seat. Usually it goes in its muscle seat. Once you are able to get the muscle seat, you can find the muscle in its seat and you can again suture it back and you can give good movements. So this is the post-operative of the same patient with the complete laceration. Snapped or pulled into two. It was, this 30-year man was hit by iron rod. This inferior rectus was pulled into two. So here the tips are usually we just pull the globe towards us, which we should not do. It further pushes muscle the back. So better to hook the adjacent muscles. Try to observe, again, if you find the muscle seat, it is in its seat only, and you can definitely suture well. So this is the post-operative movement of the same patient, which was published. But when there is complete loss of muscle with old injury, it is very, very difficult to treat. Dynamic MRI again will help to find out the muscle, or sometime we may have to take the help of EMG. So lost muscle, it is very, very old video. So I'm sorry for the quality of video. Actually, the muscle is found out, but it is not seen clearly. We inserted it back. Despite of keeping it back to the insertion, you may not get good result because it's old injury. When lost muscle, sometime you are not able to find the other part, then transposition or tethering is the procedures. And trap muscle has to be taken care whenever there is MR entrapment. In this boy, there was MR entrapment. In adults, usually we operate within first, second, or third week, and in children, within 2 to 3 days of the injury. Aim of surgery is permanently close the defect, and we have got all routes of, I'll not go into detail of orbital things here, transconjunctival, transcutaneous, or endonasal, and so many materials nowadays, absorbable materials are available like PLA, PGA. So once you are fixing the orbital fracture, the end point is most important, that you need to do force duction test, and that should be completely loose. Again, say Dr. Pradeep Sharma said that roof fracture is very common in children, so it should be treated well. So I'll not go in. Every time you are not getting only muscle injury. So in our area, Drishti Netralaya Dahood has made the rule that we have already told all the orthopedic surgeons and general surgeons, they get the patients, they call us, we go to their OT and we operate at the same time when they are operating. So such man had a multiple polytrauma. So what we do after general surgeon fixes the mandible treatment and everything, we do orbital fixation. So in this patient, I put inferior floor implant and the medial wall implant. The most important thing is FDT. See, still the FDT is positive. So again and again, you need to adjust the implant, or 3D printing is the best till it gets the negative. And this patient, this is the fixation of floor, medial wall, and the superior rim. So this is the post-operative movement patient regain. So many routes are available. So let's talk about flap tear. What can happen to flap tear? The partial laceration of the muscle, and that can incarcerated, the part can be incarcerated in the fracture. So this is the mechanism how it happens. Lamellar part can be incarcerated. There has been 3-4 types of the flap tear. This is simple longitudinal flap tear. This is again a case of longitudinal flap tear. This is beveled flap tear. This is a lamellar flap tear. So, and sometimes you find that that can be a retracted flap tear. So that flap also can be avulsed from the insertion, from the mucocutaneous junction, or from the posteriorly from the lamellar area. So this baby, when we took into OT, we found that the muscle was, half the muscle was, and gave the history of, and you can see here also, the part is already incarcerated. So in that case, you can find out, it's best. Sometime you are not able to find out, better to leave that posterior lamellar part, cut it and let it go, so that then we can treat it as a fresh strabismus patient. That is the secret of treating flap tears. Retracted also can be sutured well. Sleep muscle, everybody knows, when muscle sleeps in its sheet, open the sheet, take it back and suture it back. So that is possible. This is Itrogenic trauma. Patient presented to us after sinus surgery, and you can see that medial and inferior rectus are together, adhere with each other. So we opened the orbit, we treated muscle first, and then later on we treated for ptosis correction. Sometime patient may present with bupivacaine injection, very thick muscle, or orbital inflammation. Don't leave only treating the muscle. You may have to treat all thigh injury and ptosis also. I'll not go into detail of it. This is a very interesting case. You can minutely observe that the globe itself is pulsatile. So that observation always pays rather than sending for the hi-fi investigation. So that is definitely a carotico-cavernous fistula. After ligation, we treated for strabismus correction. Third and sixth nerve palsy already has been told, so I'm not going to detail into it, but this is traumatic third and sixth nerve palsy. Whenever there is third and sixth nerve palsy, both patients in ortho in primary gaze, nothing to do better than don't touch the patient. The gynecologist had fourth nerve palsy treated, but most of the patient, when they present with later on, they will have spread of comitance. So treat as a fresh strabismus patient when they are coming with the spread of comitance. Be aware of the pseudo strabismus when they are presenting. So this is just a simple symblepharon or palpebral fissure changes or artificial eye that may lead to the pseudo strabismus. So in conclusion, better observation, proper investigation, and experience makes the surgeon best. So in our COVID-19 area, I think also in our rural area, when they are sitting home, the children are not sitting home actually, they are playing with sticks. So we published this article, we got maximum number of injury in children during COVID time. Thank you, these are my references. Thanks to my patients, thanks.
Thank you, Dr. Shreya. You covered a very large area in a very small time, and a lot of things we saw in a very in a broader turf. It's the inferior rectus which is the most likely muscle to get injured because of the Bell's phenomena, and after that medial rectus and other things do happen less often, SR and LR. And I think it was a very broad topic, so what you covered very well. Dr. Pradeep, would you like to say something? She has covered very well, I think. So, Dr. Subhash? So, yeah. I think with that we come to the last talk of this session by Dr. Sumita Agarkar. Everyone knows her, she doesn't need any introduction, and she will be talking on Duane Syndrome, which is again a very difficult and complicated situation to diagnose and to manage.
Good evening,
Dr. Sumita.
and thanks for being here despite being the last session of the day. So Duane syndrome, as we all know, is now been reclassified as cranial degeneration syndrome, has variable clinical features, which is the main parts are basically a motility limitation in combination with features which are suggestive of tight muscles. So just to get a recap, Duane syndrome can have limitation, as I said earlier, limitation of ocular motility, strabismus, narrowing of palpebral fissure, upshoots, downshoots, and abnormal head posture to overcome any of the above or for maintaining binocular single vision. So classically, we have all learned about Huber's classification, but I think based on primary deviation, it is more useful from surgical planning point of view to classify them as isotropic, exotropic, or orthotropic Duane syndrome. So ESO-DRS, mostly isotropia in the primary gaze, may have head posture like this gentleman, and sometimes palpebral fissure changes as noted classically in the literature. This is a patient with exotropic Duanes. As you can see, limited adduction, but not so much of abduction, and not so much of narrowing of palpebral fissure, but a head posture. So when you're looking at isotropic Duanes, which is most likely to be confused for lateral rectus palsy, sometimes occasionally infantile isotropia, they can be classified for Mobius syndrome as well as sometimes rarely oculomotor apraxia. So the only thing which you have to differentiate from Duanes and lateral rectus palsy is to look at the primary angle deviation. If you look at the picture above, which has lateral rectus palsy, both of them, if you see here, have dramatic abduction limitation. But if you look at their primary gaze, there is a fairly large angle esotropia in the primary gaze in the patient with lateral rectus palsy, while this child with Duane syndrome, despite having a fairly marked abduction limitation, has almost straight-looking eyes. So why these patients need intervention? For this variety of reasons, but most important are these which I have mentioned in this slide. So when to do nothing? Before we plan surgery, you should also know when to do nothing in case of Duane syndrome. If there is a minimal head turn or a small angle strabismus with good functional binocularity, you should not do anything. You should also not do anything if patient has any unrealistic expectations out of surgery. So if you see this child has a minimal face turn, the slides are moving by itself. So this patient, I would not recommend doing any surgery except watching carefully. So if you are looking at operating for strabismus, it's not only the primary deviation or the amount of deviation which is important, but also you have to look for incorporating is he moving from there? It's automatically moving forwards. Go back 2 slides.
It's not moving.
No, it's moving by itself. It has a life of its own.
Now things don't move.
Yes. I think it's divine signal that finish fast.
Trying to keep time.
Yeah, keep to the time. So So when you are making surgical plans for these patients, you look at the magnitude of the deviation as well as FDT and the amount of anomalous lateral rectus innervation. You have to remember that these patients, most of the abnormalities are driven by an abnormal lateral rectus, and amount of that anomalous innervation determines a lot of issues which you see with Duane's. So in esotropic Duane's, which is most frequently seen, you may have to do surgery for any of these reasons which I have mentioned here. And you need a customized approach for this entity. Deviation, which is small in nature, like up to 20 PD, can be corrected with just one medial rectus recession, again depending on FDT. If FDT is tight, do less. If FDT is not that tight, do more. However, if FDT is negative, probably it's better to do a partial VRT or SRT, both of which can be, as published by Dr. Pradeep Sharma, can be done on adjustable cross-action ways also, and can be made adjustable to give you more control over post-operative result. Coexisting upshoots can be treated with Y-splitting of lateral rectus if there is a significant upshoot there. However, if the angle is large, then you may have to do a bilateral recession. Again, asymmetric bilateral recession is preferable. Asymmetric means less in Duane's eye and more in the normal eye. Again, medial rectus can be combined with a SRT or partial VRT to give more results, to correct more of strabismus. Lateral rectus co-contraction, if it is there, then VRT or SRT is not a great idea, and in that case you may have to actually do a lateral rectus recession along with bimedial recession. Bilateral cases, which are rare but can happen, and they also do well with bimedial recession combined with SRT or just IRT or even partial VRT. So this gentleman, as you can see, has a isotropic Duane's with a face turn, and all we did was asymmetric Duane's with fairly good alignment as well as correction of the head posture. This lady, however, has had a very, very large face turn with a Isotropia, and here we have done medial rectus recession with SRT, and you can see it's not fully corrected everything, but head posture is so much better than, say, here to here, where if there are significant upshoots and downshoots due to anomalous innervation, you may have to, it can be managed surgically by Y-splitting the lateral rectus, or sometimes if it is very anomalous innervation, you may actually have to take a periosteal fixation of lateral rectus or completely disabling the lateral rectus to get all of it corrected. This patient, as you can see, has a head turn, a really significant upshoot and abduction limitation. And here, after my Y-splitting, I just did a medial rectus recession and Y-split. Head tilt, head turn persists. There is probably a small Isotropia still remaining, and but her exotropic Duane's is less frequently seen. More associations of lateral rectus co-contraction are present in these entities. And exotropia can be managed by large recession, and it's like really large recessions. And sometimes you may have to combine it with a Y-split if there is a really severe upshoot. Again, periosteal fixation may be required if there is absolutely no normal lateral rectus activity in abduction. So this is this girl who you can see in the she has a fairly face turn and a really, really large upshoot and an exotropia in the primary position. And we did a lateral rectus recession along with Y-split, and most of her issues are sorted out. Although when she came back 6 weeks later, this is first post-op day, she looks much better in this picture, but when she came back 6 weeks later, she still had a little bit of face turn and may need additional surgery. So again, abnormal head postures are mostly to compensate for isotropia or exotropia, but sometimes also to avoid upshoots and globe retraction. So this patient clearly has esotropia and compensating for esotropia by head posture. But this gentleman has an head posture to avoid the co-contraction and the upshoot which is there. And post-surgery with Y-split, as you can see, his head posture is so much better because his head posture was not directed by strabismus, but by the severe this. Now, this is something a new kid on the block and can be considered in very young children. There is only one paper on this by Dr. Kumar that if you diagnose Duane syndrome less than 1 year of age, Botox can obviate the need for surgery and can also cause complete resolution with a single injection with younger children. What can go wrong post-surgery? Overcorrections happen. Sometimes you can induce torsional diplopia following SRT or VRT. And sometimes in transposition procedures, you can also induce new vertical strabismus, which was not there earlier. And in that, if any of these two things happen, it is best to explore as early as possible in the postoperative period. And this must be, especially if you're trying or planning transposition, this must be discussed with the patient before you do the surgery. Thank you for your attention.
Thank you, Dr. Sumita, for covering a very diverse and difficult topic in such a short time. I would just like to say that I think refractive correction is important in these cases. Quite often they are hypermetropes.
Yes.
And if you can even correct the deviation because they could be having an accommodative component, and that may be the only thing which may be required. So refraction amblyopia is not very common because they managed to adopt an AHP, so they don't have amblyopia that often because of the strabismus. Otherwise, they can have amblyopia. And then, of course, MR recession one should be careful. If there is more co-contraction, then you should not do too much of MR recession because it may send the eye into an exo. So that is also important to keep in mind that you be slightly careful with MR recessions in these cases.
Less is more.
Yes, less is more. And bilateral cases have a lot of genetic issues. So if you have bilateral case, think of genetics also. So I think, Dr. Pradeep, would you like to say something?
I think you have summed up all the additional concerns.
Yeah, and I think shoots and globe retraction are most difficult to handle, I think. Some residual thing quite often will remain. Deviation HP is still easier to correct, but shoots, those bad ones and bad globe retraction, I think they are very difficult situations. Anything, Dr. Pradeep, like to say something? Dr. Shreya? Dr. Subhash? So, Dr. Pradeep, can give some concluding remarks? So, thank you all of you. It was very interesting and nice discussion. Thank you so much.
We are finishing on time.
Yeah, we finished on time. So.